Hello, and welcome to this Through Your Patient's Eyes educational program. Today, we will be discussing identification of severe asthma and best practices for coordinating multidisciplinary care. I will be with you. I'm Barbara Yawn. I'm an adjunct professor in the Department of Family and Community Health at the University of Minnesota. And joining me is Dr. Mike Wexler, who is Professor, Department of Medicine at National Jewish in Denver. Welcome, Mike.
Thank you, Barbara. It's great to be here today with you to talk about asthma.
Many of the resources that we will discuss during this program can be found on the Severe Asthma Clinical Resource Center on the ExchangeCME website. Please visit www.ExchangeCME.com/asthma resources. Mike, let's begin today with an overview of first, what is asthma, and then talk about the types and severity of asthma. Can you start that?
Sure, Barbara. So asthma is a chronic inflammatory disease of the airways in which patients have shortness of breath, cough, wheezing, and chest tightness. And it affects over 25 million Americans annually. And it's due to a variety of different inflammatory factors as well as environmental and genetic causes. We normally think of asthma as being divided into severe asthma, non-severe asthma, or persistent asthma and non-persistent asthma, or controlled or non-controlled asthma. And it's important to sort of recognize asthma in its manifestations and how to differentiate between those different subgroups.
I think that's a great way to start because people sometimes just lump it all into persistent and non-persistent, and that really ignores a whole lot of the important facts that we need to really go over. Let's take a minute and look at a video that shows us what asthma can do and how it can affect a patient's life.
Hi, Joanne. I'm Mike. I have a short questionnaire for you to fill out about your asthma. If you can fill it out, the doctor will come in and review it with you.
Thank you.
Thank you.
In the past 2 weeks, how many times did any breathing problems, such as asthma, interfere with your activities or activities you wanted to do? Well, that's easy, more than 3. Gee, just last week I missed Kevin's concert at school. Still upset about that one. I know he said it was okay, but I can't believe I couldn't be there for him. And then Saturday, I missed Al's big game. What kind of mother am I? Oh, I better stop thinking like that. Next question. How many days in the past 2 weeks did you have shortness of breath, wheezing, chest tightness, cough, or felt you should use your rescue inhaler? Again, 3 or more days. It's probably like 5 or 6 days out of the last 2 weeks. Wonder if I should mention to her that I seem to be using my rescue inhaler a lot more recently. A lot more. I hope I don't need to switch medications again. That's such a pain. Or worse yet, I hope she doesn't add any more inhalers. How many nights in the past 2 weeks did you wake up or have trouble sleeping due to coughing, shortness of breath, wheezing, chest tightness, or get up to use your rescue medication? Yes. Can I just answer yes? Oh boy, again I need to answer 3 or more. What I wouldn't give for a good night's sleep. All that coughing. The kids even said they heard me the other night. I don't want to keep them awake too. What about all those days of work that I've been missing? I don't even want to think about how many days I've had to call out sick this year. I hate this stupid asthma. Ruins everything for me.
That video gives us a look into what the patient is thinking and feeling even before we get into the exam room. It's important to think about the diagnosis of severe asthma and how it can affect our patients. Compared with people with other kinds of asthma, non-persistent, mild, moderate, what is it like to have severe, and what kind of burden do you think about?
Well, there are millions of people who suffer from severe, refractory, difficult to treat asthma, brittle asthma, if you will. And those patients have uncontrollable symptoms. They have frequent symptoms. Even many times a week, they'll complain of chest tightness and shortness of breath and coughing or wheezing. And they'll need to use their rescue inhaler many times a week. It's asthma that interferes with their daily activities. It interferes with work. It makes them miss school. And so it's important to recognize that asthma severity can change over time, and asthma control can change over time. And it's up to us as physicians to try to work with our patients to figure out exactly what is causing the asthma in that specific individual. Is it an inflammatory component? Is it a genetic component? Is it an environmental component? Or is it something as simple as actually just taking one's medication?
Right, adherence, huge, huge problem. We know that patients that have asthma do not take their medication even though they need it, and they know they need it. The other thing that I always worry about is inhaler technique. We give them 3 inhalers, they have 3 different techniques, and nobody checks it. What do we want our primary care colleagues to know about the pathophysiology of severe asthma?
Well, asthma is an inflammatory disorder that is made up of many different pathways that cause inflammation within the airways. There are a variety of different cytokines that are involved, interleukin 4, interleukin 5, interleukin 13 amongst them. And there's many different cells that play important roles in asthma. Eosinophils, neutrophils, mast cells, basophils, and many other structural cells play important roles in the inflammation and the pathophysiology of asthma.
Well, for a long time, all we had to know was it's an inflammatory disease, because all we had were some very high-level anti-inflammatories. But now, as we have new information and new drugs on the horizon, it's important to know about some of those subparts of the inflammatory cascade.
Well, there's an interplay between the different cytokines, and there's both an environmental and genetic cause to how these cytokines interact with the different cells and with one another. So interleukin 5, for example, that is an important cytokine, IL-5 it's also known as, that plays a role in eosinophil development, in eosinophil maturation, eosinophil differentiation, and release of different eosinophil mediators like eosinophil-derived neurotoxin, eosinophilic cationic protein. All of those substances cause inflammation within the airways, within the cells, and cause some of the mucus production, etc. Another cytokine that's important is interleukin 4. Interleukin 4 and interleukin 13 both bind to the IL-4 receptor and cause inflammation at the epithelial level, cause production of nitric oxide, for instance, all of which play important roles in the pathophysiology of asthma.
And this is really different than when we were talking about just IgE, which was the first different, if you want to call it that, asthma medication we had, were the anti-IgEs. So the IgE, we always think, oh, that's with mast cells and the release of all of their different inflammatory products. But now we're actually working on the eosinophils themselves.
So IgE is an antibody that binds to mast cells, and on the other end of the antibody, it binds to different allergens. And it's quite upstream in the pathophysiology of asthma. What happens is the IgE binds to allergens when it's bound to the mast cell, and when it cross-links with another IgE bound to the allergen on the mast cell, it causes the mast cell to degranulate and release its mediators, things like histamines and leukotrienes and platelet activating factor, and that causes some of the inflammation and some of the recruitment of the other cells, including eosinophils, that releases its own mediators. And so it's a very complicated mechanism, but it's important to recognize that all of these features can be at play in different patients.
Well, obviously, as we talk about specific cytokines, and you mentioned different patients have different ones, potentially at different times, this must be what's leading to the interest of phenotypes. Can you talk a little bit about phenotypes and what's the clinical importance of phenotypes, and why would I bother to figure it out?
So asthma is a very heterogeneous disease. I've already talked about the different mechanisms that are at play. And then there's all sorts of other different factors that cause interactions and can affect asthma in different ways. So a phenotype is a descriptor of the specific patient that we can observe. So it would be things like, I'm tall versus I'm short, I'm fat versus I'm thin, I'm black versus I'm white, I'm old versus I'm young. Those are all descriptors of phenotypes. And we know, based on several of our studies that we've done over the last few decades, is that patients of different phenotypic characteristics respond differently to different therapies. We've shown, for instance, that older patients may respond less well to inhaled corticosteroids than younger patients. Blacks may respond less well to beta agonists than Caucasians. And so it's important to recognize some of these differences so that we can try to personalize our approach to our patients. If we can say, okay, well, this person has a specific kind of phenotypic characteristic and will respond one way, then we can try to treat the patient with that specific therapy. Now, what we're getting to, and we're moving, to try to personalize our approach, we've moved towards phenotypes. Now we're honing in even more beyond just phenotypic recognition, but what's causing those specific phenotypes. And we refer to those as endotypes. And those are specific patient characteristics based on the underlying mechanism. So we're calling patients, okay, you have eosinophilic asthma, you have neutrophilic asthma, you have IL-5 mediated asthma, you have IgE mediated asthma. Those are examples of specific endotypes that characterize the underlying inflammatory pathway in a given patient. And the reason that's important is because we have now developed, with our good understanding of the specific mechanisms at play in a given patient, we're developing new therapies that target those specific pathways, those specific endotypes.
We've talked about pathophysiology. Now let's get back to the patient. How do we define and identify and assess patients with severe asthma?
Well, it's important to talk to our patients, obviously, and find out, how often is he or she using a rescue inhaler? How often is he or she having symptoms? How often is he or she having nighttime symptoms associated with asthma? And how often is asthma interfering with daily activities? Those are like the key questions. How often are they having exacerbations of asthma that really, throw them for a loop and cause them to miss the work and miss school due to underlying asthma? First of all, asking those questions, that's the first step. But then using spirometry, for instance, using breathing tests to assess the degree of airway narrowing in a given individual.
So do I need to do spirometry on every patient with asthma, or especially focus on those who maybe are uncontrolled or having more problems, more exacerbations?
In patients who have asthma, I would at least do it at some point to get a sense of how severe their lung function decrement may be. And then use it as needed in patients who continue to have symptoms to follow lung function as a metric, perhaps, of outcomes. There's other outcomes as well that we need to examine. So you can follow lung function, but we have several questionnaires that we utilize as well. Mm-hmm. The asthma control test, the asthma control questionnaire, the attack questionnaire, the asthma APGAR score. Those are all very useful tools to engage the patient. They're brief. They're usually only 5, 6, maybe a few more questions that really give us a sense of how active a patient's asthma is.
Well, and the patient can actually fill them out before we come into the room. So you walk in the room and you have got not only the answers, you've remembered all the right questions, because in primary care, it's not always easy to move from diabetes to hypertension to heart disease to asthma and remember, okay, now what are the 3 really important daytime, nighttime activities? Okay. But you forget. So they can fill them out ahead of time, and you can also follow them over time with these questionnaires.
And we actually also, in our asthma clinic, we're a very, I would say, sophisticated asthma clinic. We also measure nitric oxide, which is an inflammatory mediator that we can actually measure based on patient breathing into a small device. And that spits out a number that correlates with degree of airway inflammation.
The FeNO2.
Yes, the FeNO, the fractional excretion of nitric oxide. Nitric oxide is an inflammatory biomarker that correlates in patients particularly who have IL-13 mediated asthma. And then there's other biomarkers that are currently in development. So one is something called periostin. Periostin is a biomarker that is derived from IL-13 cells and represents potentially underlying IL-13 mediated inflammation as well. That's still in development. It's not commercially available as of yet, but in different studies we've utilized it as a biomarker for IL-13 mediated inflammation. Another one that's also being used as a marker of IL-13 mediated inflammation is something called DPP4, or dipeptidyl peptidase 4, which may also represent a marker of IL-13 mediated inflammation. That's still in the works.
A lot of those things potentially are things that ought to be done in primary care when we have a patient with asthma, especially if we're thinking about severe asthma.
Yeah, I think that these tools are essential to help us identify patients with severe asthma and also to follow our treatment strategies. So if a patient comes in with low lung function, is that lung function getting better? If the asthma control test or the asthma APGAR score is poor, do our interventions make a difference in terms of trying to get that patient better controlled?
Well, and certainly the ACT and the ATTACK and the ACQ have all been around for a long time. The asthma APGAR is relatively new. Well, then obviously I have a bias having worked on the asthma APGAR, and the thing that it does that ATTACK and ACT and ACQ don't do, it goes on and asks about triggers, it asks about adherence, and is linked to an algorithm for care. So instead of just getting a number, which is great for you, I get a number and a recommendation of what I ought to think about next, and I think that's helpful.
Oh, I think it's invaluable, actually.
Now, we talked about what I might do in my office, and we've gone through those things, but if I send a patient on to you, what are you going to do?
It's important when I see someone with asthma, I try to have a fresh take on the situation.
Right.
First of all, the most important question I have is, does this patient actually have asthma? Many patients are told, oh yeah, you've had asthma, you had it since you were a kid, but does that patient really have asthma? So the first thing I do is try to make sure that the patient has asthma. But sometimes some patients don't respond to traditional therapies. They'll get put on bronchodilators, the medications that help open up the airways, or they'll get put on anti-inflammatory therapies like inhaled corticosteroids, and they don't respond. So we have to say, well, does this patient really have asthma? What else could be going on? And I generally break things down into other entities that may not be asthma versus entities that can complicate asthma and exacerbate asthma. Once you identify that a patient has asthma, then you have to think about what complicating factors could be going on. What else could be contributing to underlying asthma? And the things that I think about are generally related to either the upper airways or the GI tract or other comorbidities. And then another thing that I think we need to exclude is, does the patient have a respiratory tract infection, a chronic, lingering respiratory tract infection that goes untreated? Does the patient have mycoplasma? Does the patient have chlamydia in the airways? Or does the patient have some other kind of chronic respiratory, indolent respiratory tract infection that is causing symptoms? we also need to look at other comorbidities. Does the patient have obesity that could be contributing to some of their symptoms? Does the patient have depression? And then another entity that often coexists with asthma is something called vocal cord dysfunction.
Right.
In which the airways, when an individual breathes in, actually come together and cause what sounds like wheezing, but is actually just an upper airway dysfunction, and causes some of the narrowing and symptoms associated with asthma.
Well, and all of these are things that I'm not going to do in my office. Yeah, I may realize, and I need to realize, there are other potential problems, but if I've worked very, very hard to treat this patient, they're adherent, they have good technique, I can't find any obvious triggers, there's nobody smoking at home, for example. If they're allergic to cats and dogs, they aren't sleeping with them. Then it's time for me to say help and let you explore these things. I'm not going to explore those in my office.
But there are other things that you could do that can help characterize our patients, that can get to the underlying phenotype of our patients. And just simple things in terms of excluding some of those things, like doing a chest x-ray may be helpful. Doing spirometry, I think, would be helpful in helping characterize those patients.
And how about allergy testing?
Allergy testing is critical because it helps us identify what patients are allergic to, what could be triggering the asthma in a given individual. Sometimes patients can't identify that it's a specific food or a specific tree or pollen or plant or something that's going on in his or her environment.
And many of those we may be able to do, not the food allergies, but with a blood test that gives us at least a screening panel. We don't always have to do just skin allergy testing for the first go-round.
Yeah, you can do what's called RAST testing, and that you can do for specific entities and find out what a given individual is allergic to.
I want you to look at this video with me. This is of a patient that I saw. She actually made her follow-up visit after her asthma exacerbation when she went to the ED, but she's still not doing well. Let's look at this. Hello, Joanne. It's really good to see you today. How are you doing?
Okay. Yesterday and today were pretty good, and I slept a little better last night.
She said she's good, but these results are certainly not consistent with someone who's doing well. I'm glad you came back after your emergency room visit. Not everybody makes their follow-up visit, so that's great. I'm glad you did that. But I'm looking here at the APGAR score, and it looks like you're still having a lot of symptoms, a lot more than I really want you to.
Well, yes, that is true, but I am taking the inhalers like you showed me. I hardly ever miss.
Good.
And I still am having problems. And your nurse watched me today and said I was doing it correctly.
Yeah, I see that she did, and I'm glad. That's really important because, as you know, if you take it but you don't do it right, you don't get the medicine into your lungs. And so I'm really glad that she checked that. Looking at your APGAR score in more detail, I see that, it looks like 3 or more times for the activity changes, the daytime symptoms, the nighttime symptoms. And down here, I do notice that it says you're using your rescue inhaler several times a week. In fact, sometimes even several times a day. Plus, I know you're on the combination medicine. We moved it up to the stronger one. And you got the asthma pill because of all your allergies.
Yes, I am taking the asthma pill and the new stronger inhaler you gave me. I finished the antibiotic and the prednisone they gave me in the emergency room.
That's great. I'm glad that you finished those. Not everybody does, so that's good. Let's look at the rest of your data too, because you have some other information here. I know you've been to the emergency room twice in the last 6 months, including the recent one you did. And we obviously want to keep you out of the emergency room. Oh, and good, I see you did your spirometry, your breathing test. That's really important. But this is a little bit abnormal. Let's look at it together. We've done spirometry on you before. And you remember, this is where you breathe in and then you blow out. And we measure how much you blow out. And what this one says is that in that first second, which is really important, you only got 70% of what we expected. And it did go up after you took the medication, and that's really good, but this is not where we'd like it to be.
So my lungs aren't working well?
No, they're really not working like we'd like them to, and this is due to your asthma. And I think that actually you probably have severe asthma when we take into account.
Severe asthma? What does that even mean? Oh, I'm probably going to need to have another inhaler. I wonder if this means that my asthma is getting worse. I hope we can treat it quickly. What's going to happen to my work? I take so much time now. What about the kids?
You look a little concerned. Did what I say bother you? The severe part, is that what concerns you? Mm-hmm. Well, let me explain a little more. I can understand how that would be kind of frightening. What severe asthma means is that we are not controlling your asthma, that you are having lots of symptoms, but I think there are things we can do. We aren't at the end of the line with treatment at all. I think that there are some new medications that are possible. I'd really like it if you would see one of my colleagues, Dr. J. He's a pulmonologist, and I think that he could help us with those newer medicines. They're called biologics, and he could see if maybe there's some other tests or things that I haven't done that would point out things we can do to help you. What do you think about Dr. J? Are you open to that?
Yes, I guess so. I think my asthma is getting worse. I don't like to admit it, but it's also interfering with my life. I'm worried about how many days I'm taking off work. I've hardly have any sick time left.
Yeah, and you know, we don't want you to keep taking days off work. So let's go ahead and schedule that appointment. Now, it may take 3 or 4 weeks for you to get in. He's busy and it takes a while to get in. So while we're making the appointment, let's go over your asthma action plan. We've talked about this before, but if you have problems, I want you to know what it is that you need to do. Do you remember this? We did the green, yellow, and red. And the green is when things are going okay, you're really not having any extra symptoms. As you saw, she has been to the ED twice in the last 6 months for her asthma. She's missing a lot of work, lots of problems. Her asthma control score, her asthma APGAR is actually 6, lots of problems with missed activities, changed activities, symptoms during the day, symptoms at night. She is adherent to her medications, and we did check her inhaler technique. So this looked like severe asthma to me, and that she needed some more help beyond what I could give. What else would you do with this patient, and do you think she has severe asthma?
So, I think she has frequent symptoms. She's going to the emergency room. So to me, this sounds like severe asthma, but I would want to characterize the patient further. First of all, what's her spirometry like? What's her lung function like? And then I want to try to get a sense of what's causing severe asthma in her specifically. First of all, what are the triggers? Have we done allergy testing or RAS testing to try to get a sense of whether or not the patient is allergic to specific features that can be exacerbating her asthma. And then we want to get a sense of what the underlying endotype is. What's the mechanism of her severe asthma? So, have we checked a CBC with differential to look at eosinophils? Have we checked an IgE to get a sense of whether or not this is allergy-mediated asthma? Have we checked a nitric oxide level?
What are the kinds of phenotypes you're going to be looking for?
So there are several different kinds of asthma that we see. There's allergic asthma, where someone's allergic to some trigger and that causes the inflammatory allergic cascade from ensuing. But there are also patients who have non-allergic asthma, and these are often patients who have some other kind of inflammation, IL-6 mediated inflammation that may be going on, or even eosinophilic inflammation that could be going on in a given patient. Then we try to think about different phenotypes, different patient characteristics. Does the patient have early onset asthma? Does the patient have late onset asthma?
Well, and as you saw, Joanne is not overweight, but obesity really aggravates asthma too, doesn't it?
Sure. So obesity can affect asthma both physiologically in terms of the mechanics of breathing, but also in terms of some of the cytokines that are prevalent in patients with obesity. Another thing that I think is important, this patient clearly has exacerbation-prone asthma, and that can be different between patients who have severe sort of lingering symptoms on a frequent basis versus those that have frequent severe exacerbations that really can affect individuals' lives over time.
What are some of the challenges that we need to overcome in making a diagnosis of severe asthma?
Well, as we talked about, there are many comorbidities that can affect patients with asthma. Patients who are elderly, for instance, may have heart disease. They may have obesity. And they may have concomitant respiratory tract infections. How are those factors influencing this specific asthma phenotype in that given individual? But then there are other factors as well that can cause exacerbations of asthma, whether it's sinus disease or postnasal drip, or whether it's gastroesophageal reflux, or whether it's obesity. All of those factors can influence, first of all, the cytokine milieu, but also the mechanics and pathophysiology of breathing.
I want to move on now to some of the newer therapies, the so-called biologics. And these are something that as primary care physicians, most of us are not prescribing, may never prescribe, but we really ought to know about these because if I don't know, then I'm never going to send them on to you for consideration. You remember we saw the video a little while ago about Joanne and specifically told her that I was thinking that maybe biologics might be helpful for her. So now she comes to you. What are you going to tell her and what can you tell us that we should know about those biologics?
Sure. So first of all, it's important to recognize when to refer these patients to the specialist. And in general, patients who are not responding to standard of care therapies should probably be referred if they continue to have symptoms or if they continue to have exacerbations. Over the last decade, we've had new therapies like anti-IgE emerge. So that's a great example that many primary care doctors are not aware of, that this therapy has been available for over a decade. So anti-IgE therapy with omalizumab has been shown to reduce asthma exacerbations, improve symptoms, reduce nighttime awakenings, and really have a significant impact on the quality of life.
But we don't use it on everybody. That's for a certain phenotype or subset?
Yeah, it's patients who have allergic asthma. And so it's patients who have allergies that exacerbate the asthma. It's for patients who have got moderate to high IgE levels that can be targets of this novel biologic therapy. But over the last year or two, we've developed other therapies that target specific pathways, that target specific entities within the asthma pathophysiology spectrum. And so, for instance, novel therapies that have been approved by the FDA include the anti-interleukin 5s. And so by giving anti-IL-5, we can prevent eosinophilic inflammation from ensuing. And several studies have been done with different biologics that target IL-5. One therapy is called mepolizumab. that binds IL-5 itself. Another one is called reslizumab. Both of these therapies over the last several years have been shown to reduce exacerbations by about 50% and also to improve lung function and improve symptoms. So there have been several studies that have been published that have demonstrated that by blocking IL-5, we can have a significant impact on eosinophilic mediated inflammation and have a significant impact on the management of our patients. Another therapy that is currently in development is a drug called benralizumab, and that doesn't bind to the IL-5 itself, it binds to the IL-5 receptor. But it has the same kind of impact. It reduces exacerbations, it improves lung function, and has a significant impact on how we manage our patients.
And all of these are on top of current therapy, so you don't stop therapy and start these, you continue current therapy.
And they really had a huge impact because these patients oftentimes were treated frequently with systemic corticosteroids like prednisone that caused all the side effects that steroids cause.
And I think it's important to say steroid courses, not just the daily. We all know we don't want any patient on daily steroids, but I think sometimes we forget that taking 3, 4, even 2 5 to 10-day courses of oral steroids, we're not talking small doses here, we're talking 30, 40, 50 milligrams a day for maybe 5 to 10 days. This is significant.
Absolutely. There are other therapies that are also in development. Anti-IL-4/13 receptor, for instance, dupilumab, is another excellent example of a therapy that's in development that can have a significant impact on how we manage our patients. That therapy blocks the IL-4 receptor. It also prevents IL-13 from binding. It's been demonstrated in some of the phase 2 studies that that therapy reduces exacerbations by 70 to 80%. So if you can reduce exacerbations by that magnitude, that could have a significant impact.
Are there others that are also?
Yeah, so there's other therapies that are in development. There's IL-13 specific therapies that are in development. One drug is called lebrikizumab. Another one is called tralokinumab. They're currently in development, neither of which has been approved.
So we can actually have personalized therapy at some point.
It's trying to get to a personalized approach where we give the right medication to the right patient.
And that'd be exciting. What about the safety profile? I know there's a black box warning on omalizumab, for example. Should we really be concerned about the safety profile? Because you may start the patient on these drugs, but they're probably going to come back and see me between visits to you. So what do I need to know?
These therapies are generally pretty safe. You know, they're quite effective in terms of their efficacy. There are some potential, as with any medication, of having an adverse reaction. The thing that patients complain most about is that these are generally injectables or they're given intravenously. And so, you know, there is a certain amount of, pain when given subcutaneously with an injection. You can have a local reaction. But there is a theoretical possibility of anaphylaxis in a very small proportion of patients given any of these biologic therapies.
And how small are we talking about?
Much less than 1%. And so, we generally monitor patients for about an hour after each shot in order to make sure that the patient is tolerating the medication and is not having any issues.
And does the risk of anaphylaxis go down after they've been on it for a while?
Yeah, we generally, after a patient's been on a therapy for several months, their risk is much lower. And the need to observe the patient, should be managed on a case-by-case basis.
And so it's possible that you work and I work together, and after 6 months, perhaps the patient who lives 100 miles from you might be able to get the injection in my office if I'm comfortable and have the staff?
Absolutely. I think that in terms of initiating these therapies, I think it's worthwhile sending to a specialist and making sure that the right medication is getting to the right patient. There's no reason why a primary care doctor shouldn't be able to administer these therapies as long as they're set up to either give a shot or set up an IV in his or her office.
Well, I want you to take a look at the next segment. This is Joanne's visit back to me after she'd been off to see the specialist. Hello, Joanne. It's good to see you again. How was your visit with Dr. J?
We did talk about how my asthma is severe and how my medications weren't working well, which is why I ended up in the emergency room again. He did talk about some new therapies. He called them biologics.
Right, biologics.
And he said something about injections, but I didn't understand the difference between the shots and the IV. I wonder if you could help explain that to me.
Yes, they are injectable. The biologics are injectable. And the shot means like you get a shot of penicillin, you know, you get it in your arm or you get it in your hip, or when you get your flu shot, that's what an IM or injection shot is. The intravenous, that's where they put a needle in your vein. You know, you've seen on TV where people get the IV, the clear liquids that go into their vein. They put the needle in there. It takes about 20 minutes for all the medicine to run in. Then they take the needle out, put a Band-Aid on it, and watch you for a little while, and you're good to go.
What has been your experience with biologics? And do you think they could work for me? I wonder also about how safe they are, and will there be any side effects?
Those are great questions, and I think that we should go over those a little bit. We've talked about the injectables, but Dr. J did send me a really nice letter that covers the different side effects and all those things. So let's look at it a little bit. Here, I've got it here on my computer, and we can just go over this. Okay, so you can see.
Thanks for giving me all these details. And it does seem that these biologics are pretty safe.
I think so.
And I wanted to talk about, you said that we should check with the insurance to see if they'll cover it. Dr. J said it could be expensive.
Yes, he's right. These can be quite expensive, and so let's do check your insurance before you go back to see him. And what I'm going to have you do today is see one of our patient representatives, and she can look at your insurance plan and see whether or not they cover these, and then we'll know. So let's go see her. So when Joanne came back, it was like it is with many patients. They saw the specialist who spent quite a bit of time with them, but they still have a bunch of questions, whether it was that they just couldn't absorb that much information or they just need reassurance. Okay, let's move on from biologics to other new therapies that may not be brand new, but more recent for asthma.
Yeah, so the long-acting antimuscarinic agents or the anticholinergic agents have been available for the management of COPD for well over a decade, almost 2 decades. And therapies like tiotropium are available and were just approved for asthma in the last few years. So tiotropium is a long-acting antimuscarinic agent that helps improve bronchodilation and acting on the cholinergic system to try to mediate and mitigate some of the inflammation that's derived from the cholinergic pathways.
And in COPD, certainly we're talking about using both the beta agonist, the long-acting beta agonist, and the long-acting antimuscarinic. Are we doing that in asthma? Are you doing that?
Yeah, so I use it as add-on therapy, as first-line add-on therapy to patients who are poorly controlled with inhaled steroid and a long-acting beta agonist. So patients who are on that dual combination therapy who are poorly controlled, and particularly those who have got poor lung function, the first medication I'll reach for may be either a leukotriene modifier or one of these long-acting